Good evening, ladies and gentlemen, and welcome to episode 6 of the Royal Society's Medicine series on health emergency of climate change. And in this evening's episode, we're going to be talking about the unborn child and children's health. My name's Lesley Regan, and I'm an obstetrician and gynaecologist based in London at Imperial College at the St Mary's campus. And I'm joined this evening by my co-chair, Dr. Panicos Shangaris, who is the president-elect of the RSM's Maternity and Newborn Forum. Panicos is a clinical lecturer in maternal and fetal medicine at KCL, and he completed his PhD in fetal medicine at UCL, funded by the Wellcome Trust Sparks Training Fellowship and UCLH Charities. And he has great interest in stem cell research, in utero stem cell transplantation using immunotherapy. I'm also joined this evening by two very eminent speakers, Dr. Sari Kovats, who is Associate Professor at the Centre of Climate Change and Planetary Health at the London School of Hygiene and Tropical Medicine, and then also by Dr. Kiang, who's Senior Registrar at the Royal Children's Hospital in Melbourne. Now, what we're going to hopefully do this evening is to shine a light on how important it is that we look into the unborn child and children's health, and also the fate of the pregnant woman. I think it's difficult to summarize how enormous this problem is of climate change, but as someone recently said to me, the implications of climate change for our global population of about 9 billion people threatens to undermine the last half centuries of gains in development and global health. So I'm going to start off very briefly by sharing my screen, I hope in a moment, and just setting the scene in terms of an overview of what happens with maternal health and in pregnancy. And we're going to be talking about the impact of climate change in pregnancy. I'm wearing several hats here, firstly at Imperial College, and also because I'm Secretary General at FIGO, the Global Voice for Women's Health, and immediate past President of the Royal College of Obstetricians and Gynaecologists. So we know that climate change, the crisis of climate change, is really having a very adverse effect on reproductive health. I'm going to give you a brief overview of the climate change and associated conditions and the impact of climate change on reproductive health, but both fertility and pregnancy outcomes. And I know that the two speakers that are going to follow me are also going to be talking about some of those issues too. So I'm going to try and do a very brief overview of summary about what this means for reproductive health. So the impacts of climate change, as you know, warming temperatures, changing in precipitation patterns, increases in the frequency or the intensity of extreme weather events, rising sea levels, and these impacts threaten our health by affecting the food we eat, the water we drink, the air we breathe, and the weather we experience. And you would be not surprised to hear when I say this as an obstetrician and gynecologist, of course, it's always women and children that find themselves bearing the brunt of these problems in areas of natural disaster and in these crises. So which sort of populations are most affected by climate change? Disadvantaged communities, indigenous groups, older adults, people with disabilities, those with pre-existing or chronic medical conditions, vulnerable occupational groups. But of course, for the purposes of this evening, I want us to focus on pregnant women and the developing fetus and their unborn children, our next generation. So pregnant women and their babies have two really big vulnerabilities, a psychological vulnerability and a physiological vulnerability. Mothers or during maternity, they have a relatively suppressed immune system, they have high volume, high output cardiovascular states, and they have very pregnancy specific medical conditions. And I just want to remind you of Michael Marmot's review, Fair Society, Healthy Lives, where he reminds us all, of course, that the healthcare that I was trained to deliver contributes only a third of improvements to life expectancy. And it's actually changing lifestyles and removing health inequalities. And I would suggest that the climate crisis is one of those inequalities that contributes the remaining 2/3. But most importantly, and to stick to the theme of this evening, we need to think about this as a life course approach. And we know that the disadvantage along that life trajectory starts before birth and it accumulates through life. So here are these rather critical periods of vulnerability to disruption by environmental factors, and there are many, many that we can talk about, but I just want to remind this audience that, of course, it's this prenatal period that's so important. So I'm going to think of the mother as the first generation, her fetus that she's carrying as the second generation, but of course that fetus, whether male or female, is carrying gametes that represents the reproductive cells of a third generation. And so the life course continues, and so the impacts are massive. Now, this is a very traditional view of the impact of climate change on human health, and you'll be relieved to know that I'm not going to go through all of those sectors. I'm just going to remind you that from the reproductive point of view, there's an adverse effect on gametes, on embryos, on the implantation process, and then all of the pregnancy outcomes. And let's just look at two: extreme heat and air pollution. And pregnant women are most affected by extremes of heat because, of course, their thermoregulation is compromised at all gestational ages. And this starts very, very early on. The cardiovascular system has changed dramatically at just 5 to 6 weeks, where most women are only just discovering that they're pregnant. And they're also affected by air pollution because of their very altered cardiopulmonary physiology during their pregnancy. Now, climate change and air pollution, as you know, are very, very closely linked with global warming. And I'm just going to remind you that the global warming makes the air pollution worse by extending the ozone, droughts and storms, fires and smoke, the sources of air pollution, and of course, reducing carbon dioxide emissions can reduce these air pollutants and health impacts. But for the purposes of this evening, I'm just going to try and keep this simple and talk firstly about air pollution, then a little bit about heat intolerance. And we now know that air pollution is a possible cause of fetal malformation, of miscarriage, of prematurity, of low birth weight infants, and infant mortality. And there are quite a lot of studies as well showing that it has quite a marked effect on fertility. So this is the fertility rate in China over a decade from 2000 to 2010. And here we're looking at the particulate matter 2.5 change over that time period. And you'll see that the red is the bad areas. And you will see here on the right-hand side, the rate in fertility change and the reduction in fertility, which actually maps to the lighter areas on that China graph, showing that it has a massive effect of air pollution and fine particles in particular on fertility rates. This is a study that was undertaken in the year 2011 in Mongolia, where they were looking at seasonal ambient pollution, and they correlated this with spontaneous abortion or miscarriage. And you'll see on these graphs for sulfur dioxide, for nitrous oxide, for carbon monoxide, and for particulate matter, you can see massive changes. Sorry, I moved that off. And monthly average levels versus fetal death. So these went up with the various months, increasing in the summer months in Mongolia. Air pollution and pregnancy loss, again measured by ambient particulate matter in an African study that was undertaken over a long period of time from January 1998. And here they looked at nearly 50,000 pregnancy losses across Africa. They documented 30,000+ miscarriages at less than 20 weeks and 12,500 stillbirths. And here you'll see that each increment of reduction of particulate matter was associated with an adjusted odds ratio for pregnancy loss, both miscarriage and stillbirth. And that paper came out by Zhu et al. In 2019. What about pregnancy timing? Does the exposure to the air pollution in a particular trimester determine the risk of miscarriage? Well, there have been various studies, and I think the one by Ha et al. Published recently in Fertility and Sterility is probably the most helpful here, where they did a prospective cohort study and looked at a lot of singleton pregnancies in naturally conceiving couples and demonstrated looking at them in various intervals, 2 weeks before ovulation in the pregnancy cycle, 2 weeks before the pregnancy loss, and over the whole pregnancy. And what they found was that all were associated with an increased risk of pregnancy loss. And the author's conclusion was that the increased risk of miscarriage was associated with increased air pollution exposures over the whole pregnancy, suggesting that chronic exposures are more critical than short, sharp ones at particular gestational ages. There are masses of studies, and I'm not going to go into these. You can look them all up, looking at the climate impacts on preterm birth of both heat and air pollution in this study. And then again on the adverse effect, again, of heat and air pollution on low birth weight babies, and most importantly, on stillbirth and infant death. But I just need to remind this audience, of course, that being premature, and there are many studies demonstrating the impact on premature birth, is probably the most dangerous journey that, or event that ever happens to a human being born too early. So it's important then to look at the preterm birth global data. And this is Chris Malley's work that was published in February 2017, again associating preterm birth with associated fine particulate matter exposure. And they showed that in this time period, there was associated number of preterm births with fine particles was about 2.7 million, 18%, nearly 1 in 5 of all the preterm births globally, a massive, massive burden. And this period here, you will see the percentage of total preterm births, and you'll see how the orange and red bars, which are over in Asia, Southeast Asia, and into China, are particularly important. But perhaps the most important contribution has been made most recently by Bruce Becker and Nate DeNicola from the US, looking at the association of air pollution and heat exposure with preterm birth, with miscarriage, and with stillbirth. And this is their systematic review, which was published very recently in JAMA. And here they saw a massive increase right across US states of preterm birth and low birth weight in those pregnancies or women and their babies who were exposed to small particulate matter or ozone. I think this is also very interesting. If you haven't seen this clarion call, the invited commentary accompanying that original study in JAMA by Linda Giudice, who also is the chair of the FIGO Reproductive Development and Environmental Health Committee at FIGO, pointing out that these findings of Becker and colleagues are really remarkable because the studies that they included in their systematic review had very varied study designs. They were taken at different times and durations of exposure during gestation. They were very detailed. They were different associated comorbidities. They looked at a very heterogeneous group of air pollution components. They used different methodologies. They varied their different definitions of heat. And they also looked at genetic variabilities and ethnicity. So really a very, very useful edition of JAMA talking about this particular problem. So I think it's important for us to remember that climate change and air pollution affect reproductive competence. I've already mentioned very briefly and going through this at whistle-stop speed, infertility, poor pregnancy outcomes, including miscarriage, preterm birth, stillbirth, heat effects on maternal physiology, and actions can reverse effects because there have been studies now shown in California where closures of coal and oil power plants have actually shown a decrease in the preterm birth rates in nearby communities within a shorter period as 5 years of closure. And similarly, you could argue that with the preterm births, you could draw a correlation with the public smoking ban introduced in Scotland back in January 2006, the dramatic reduction in the numbers of preterm births when public smoking, i.e. outside air pollution, was put into place. Now, I haven't got time in my short presentation, and I don't want to confuse the issue by going into the endocrine disruptors, but of course, for a gynecologist who's particularly interested in miscarriage, endocrine disruptors are many, varied, and all over the place. And we know, of course, that there are great synergies between endocrine disruptive chemicals and climate change, because the warmer temperatures increase exposure to toxic chemicals, and the impacts of extreme weather events include concentrated releases of those chemicals, so climate change can exacerbate the health impacts of air pollution. And these toxic chemicals are also going to hinder the body's ability to adapt to climate change. So we know that endocrine disruptors, and I can't go into that now for the sake of time, have an effect on ovarian function, pubertal timing, menstruation, endometriosis, pregnancy loss, reproductive senescence, sperm counts and quality, fertility issues, and all pregnancy outcomes. So I'm just going to leave you with a couple of plugs for FIGO and the International Journal of Gynaecology and Obstetrics, looking into the reproductive health impacts of exposure to toxic environmental chemicals. And this publication, which came out in 2015, had some important, I think, statements and comments to make about the climate crisis and health statement and pregnancy and climate change. So I advise you to go onto the website, the FIGO website, where you'll find plenty of materials to look at. And also their recommendations for preventing exposure to toxic chemicals, advocating for policies to prevent exposure, working to ensure a healthy food system for all, making environmental health part of e-health care, and also championing environmental justice. And you will all be aware of the report in the Lancet of 2019 on health and climate change, challenging us all to think about the fact that ensuring the health of a child born today is not defined by a changing climate. And with that, I'm going to pass over to the next speaker. And perhaps I can ask now Sari Kovats to give us her presentation. Sari, as I said earlier, is Associate Professor at the Centre on Climate Change and Planetary Health at the London School of Hygiene and Tropical Medicine. She's been researching the effects of weather, climate and climate change on human health for more than 20 years. Her particular areas of interest include health impact assessments of climate change and epidemiological studies of the effects of climate, weather and weather events in urban and rural populations. So Sari, you're incredibly well placed to speak to us this evening about climate change and maternal health, particularly focusing on the evidence for adaptation and resilience. Thank you so much. The platform is yours.
Thank you. So thanks very much for the introduction. So I'm not a maternal health specialist. My background is in environmental epidemiology, and but I've been working in climate change for quite some while now. I'm contributed to some of these global assessments, like from the IPCC. And most recently, I've been working on the UK's National Risk Assessment, which is going to be launched on June the 16th. So please look out for that. So climate change is a huge topic. I'm not going to cover everything. I'm just giving a kind of sweeping overview of some of the research and questions that we're doing at the London School. We have a Chamna project which looks at heat and maternal and neonatal health in Africa, and also within the Health Protection Research Unit, where we're working with Public Health England about evidence for managing heat risks within the UK. So climate change is complex. It affects everything. It affects people everywhere, and it's impossible to get a kind of a thorough overview in this talk. But it's clear that maternal and newborn health are very much determined by the kind of upstream social and environmental determinants that affect health. So you've heard previously about the more direct effects of high temperatures on maternal health and how that might affect the unborn child. But we're also more interested as well in the kind of disruption of services, disruption to food supply, water supply, and some of these kind of more systemic risks that may affect future maternal health. So any actions that are taken to reduce those risks in response to climate events or in anticipation of climate events, we call these climate adaptation. But a lot of things are done that are not labelled as adaptation. So it's important to kind of bear in mind that concepts like adaptation and resilience are quite loosely applied and not necessarily operationalised. So just a reminder of what we are adapting to, though. High temperatures are extremely important. We had an extremely hot year. This shows 2020, which globally was a very hot year. And we've had heat waves in the UK for 2018, 2019 and 2020, where Public Health England issued alerts. But in managing heat risks, you're not just managing the acute or the few days when you have a very recognised heat wave event, you also have to manage heat risks throughout the year. And climate change will give us more heat waves, and these heat waves might be of longer duration. And also where it's already hot, it will become extremely hot. But in temperate areas that are not used to heat waves, there may be issues that people don't recognise heat risks. So heat is quite an unusual kind of exposure in that there's both absolute and relative risks or relative change that you need to address. So intense rainfall is also a well-recognised impact of climate change, and that leads to flooding. It also leads to the mobilisation of chemicals in the environment, and I just wanted to mention that because the previous speaker talked about some chemical hazards for pregnant women, and so there's a kind of there's a lot of interlinkages between these current problems and future problems, and also in terms of urbanisation and high-risk areas. So disasters are likely to increase with climate change, particularly in coastal areas. And changing seasonality may also be an issue in areas where seasonal patterns particularly drive livelihoods or nutrition choices. And it's not just the changing seasonality, it's the unpredictability around seasonal events that itself has a cost. So this is results for the UK using the latest climate change projections. And I just want to reinforce the point that there's a lot of uncertainty about how much the climate will change. Although we are on this trajectory for 4 degrees or more by the end of the century, it's still possible and technically possible to keep emissions within the 2-degree threshold that was agreed in Paris, or the 1.5. So there's still a lot of uncertainty and still a lot of work to be done. improving, reducing emissions, and of course any actions to reduce emissions would also reduce exposures to air pollution. But there's also uncertainty about how the world in which we will feel those future impacts. So this is modelling that was done by WHO on climate sensitive diseases. It's about future deaths. So the blue bars are for 2030 and the orange ones are for 2050. And the reason the kind of absolute impact reduces is because this model has an optimistic assumption about how malaria rates and undernutrition will improve. Now, clearly, the climate's actually increasing. Climate is changing more rapidly than we anticipated, and perhaps some of these scenarios about health improvement aren't quite as optimistic. So it really is a race to make sure that health improvements are undertaken in the health system and inequalities are reduced before the worst of the climate change conditions are felt. So we know quite a lot about heat risks. I've been involved with epidemiology on the UK population. So we have quite a good understanding of acute measures of high temperatures. It has, you can see the kind of traditional epidemic peak associated with heat wave mortality. That's for London in 2003. And as the previous speaker said, we have good evidence that acute, very hot days increase the risk of preterm birth. And there's also quite good evidence around the risk for congenital anomalies. And then we have good understanding of how temperatures increase malaria dynamics. And there's a roughly linear association between sort of bacterial infections like salmonella and temperature. But we're less clear about some of these other maternal complications. We're looking at the evidence at the moment. So it's really not, the evidence isn't very strong, partly because we don't have a lot of good data sets and there's not many studies around complications like maternal hypertension or the duration of labour. But it's worth mentioning what we know about the general population for heat risks. So people with chronic disease, such as cardiovascular disease or respiratory conditions, and diabetes and kidney disease, hospital admissions for all these outcomes increase during heat waves. So persons with chronic conditions are at risk during hot weather, although obesity doesn't appear to be a risk, at least for the UK. And there's more focus as well about settings. So there's more understanding of housing characteristics as a determinant of heat risk, and more understanding about the importance of protecting workers from heat, particularly workers who are physically active, workers in agriculture and so on, which would include pregnant women. And there's some European project that showed that there's very high levels of dehydration, for example, within across sectors. So this is the work that we're doing within our CHAMNA project, and I just want to show this about how we break down our research essentially on climate change and health. So we're particularly interested in the epidemiological, where we're looking at whether there is good evidence that high temperatures affect a range of outcomes. And we're also looking across the evidence base, so undertaking systematic reviews. There's some qualitative research, so focus groups are being undertaken in Kenya and in Burkina Faso, talking to health workers and to mothers and to family members about their understanding of heat risks and their responses in hot weather. Disruption to health services is very important. You know, there's less understood for heat because it's not causing obvious damage, but behaviours of staff, occupational risks, the working environment, and also power outages. You know, extreme heat can be associated with failures in energy supply or failures in the water supply as well. And as I mentioned, there's these wider determinants of health related to nutrition, maternal nutrition, particularly income and the ability to work can all be damaged by extreme weather. So as I've said, preterm birth is very good evidence. And in fact, most of the evidence around risks to mothers' maternal and neonatal health is around preterm birth because it's relatively easier to study and large data sets are available. So there's about 70 studies looking at these various outcomes. This systematic review was published last year. And they've undertaken a meta-analysis as well for heat and for heat waves. But it's worth noting there was also a study in the US by Basu that showed that this risk is also higher in mothers with diabetes and hypertension. So it's very important to understand, trying to identify those women that are most at risk. The research on heat and behaviour is kind of ongoing. It's being written up at the moment, but here are some kind of early results. So we know from talking to mothers that in very hot weather, it's unpleasant. You also, it's unpleasant. Your temperatures, internal temperatures raised anyway when you're pregnant, but it also causes quite a lot of stress and anxiety in the mother, and certainly when it's linked with lack of water as well, because there's concerns about hygiene. It causes sleep problems that, of course, exacerbates anxiety as well, and can affect care for the other children. What we were particularly interested in was whether it affects breastfeeding behaviour, because there's both health workers and mothers, some have a perception that babies are more likely to be dehydrated in hot weather, although other research has shown that there isn't evidence that the babies are likely to be dehydrated in hot weather, in which case they might get supplemental might supplement the breastfeeding, in which case that presents a risk to the baby. We're also interested in health-seeking behaviour, and again, preliminary results show that when it's very hot and the women have to walk relatively far to access antenatal care or to clinics, then they're less likely to go. They're also less likely to use things like bed nets in extreme hot weather, and that will increase their risk for malaria. This isn't from our study, but I just wanted to show this is the obvious visible damage of extreme weather, where health facilities are destroyed. And this was a study in Mozambique which showed that the loss of coverage by district from the cyclone. So this is populations more than within 2 hours travel time. And so quite a significant population was disrupted, and would have been disrupted for some time until they'd rebuilt those facilities. This is an example of indoor overheating within the UK. So we've had a lot of, there's no understanding of the general prevalence of this problem within the UK, but clearly many hospitals don't have air conditioning or passive cooling measures. And there are concerns about what measures to use, because air conditioning has some disbenefits as well. But this is from a hospital in Reading and the maternal ultrasound ward, I think. So we know that this is a current problem, but the NHS England is taking steps to address this. So essentially within the UK, there are two main strategies for dealing with with heat problems in the general population. One is around building codes and standards. And we currently don't have a building standard for overheating in housing, but there is work or consultation to create such a standard. And the other one is health education. It's messaging around heat advice and targeted advice. Currently, this doesn't include targeted advice for pregnant women, but it does include obviously relevant advice about limiting physical activity and also measures, so your behaviour within the house, to how to ensure that it's cooler. So we've got a good framework now of understanding the different pathways and how to identify reduce exposures at the beginning of the, so make sure that women are not exposed to high temperatures within their housing, for example, and then other interventions that could be done within clinical settings as well. And WHO has actually produced a health system resilience guidance now that can be followed. This is quite high level though, so I think what the need is to provide evidence for more specific actions that we can understand and that can be followed. And again, there's an important function for monitoring these actions to ensure that they're being implemented and that temperatures are reduced, for example. There's also quite a lot of research about barriers, why, even though we know there's some of these low-cost interventions, even within the UK, things aren't being done to address overheating risks, for example. But if we apply the WHO framework to the issue of maternal health and climate change, as you can see, there's several actions that can be done, and we're improving the evidence base for those. We're particularly interested in improving heat advice for pregnant women and making sure the best available evidence is there, and particularly identify those women who are most at risk. But I just wanted to end on a comment about it's more than just adaptation to climate change is more than just changing a bit of guidance here and there, or changing small bits of behaviour, there really needs to be kind of a broader view as well. And this is sometimes called transformational change. So it's seeing adaptation as transformation as part of a wider debate about improving maternal and neonatal health. Thank you.
Thanks very much indeed, Sari. And we're going to have questions at the end, but I'm going to move on now to our next speaker, who's Dr. Karen Kiang, who's Senior Registrar at the Royal Children's Hospital in Melbourne. And Karen is a paediatrician working in the area of refugee and international child health at the Royal Children's Hospital in Melbourne. So she obtained her medical degrees at Yale and then worked in public health at the CDC, the Centre for Disease Control in the US, where her interest in climate change and child health began. And since that time, she's relocated to Australia in 2004, where she's been extremely active in the international child health and refugee asylum seeker health space. So Karen, the floor is yours, or the platform is yours. Over to you. And we're really looking forward to hearing about young children, an overview of the health and safety challenges that they're facing. Thank you.
Thank you. Thank you. Thank you for that introduction. I sound a bit croaky. It is about 3 o'clock in the morning here in Australia, but I thought it would be much more fun to do this live rather than tape recorded. So as Dame Lesley had shown before, the 2019 report of the Lancet Countdown, and just to pull a few quotes from that, a business as usual trajectory will result in a fundamentally altered world. The life of every child born today will be profoundly affected by climate change. And without accelerated intervention, this new era will come to define the health of people at every stage of their lives. Let's see, why am I not moving? There we go. Maybe I'll just do it that way. So I feel kind of silly quoting some of Sari's work here, but using that WHO assessment of risk, we anticipate or estimate that by sort of 2030 to 2050, we will have over 250 to 400,000 extra deaths per year from malnutrition, malaria, diarrhea, and heat stress. And we know from studies back in 2007 that about 90% of the morbidity and mortality from climate change falls amongst children. And almost all of that occurs amongst those living in developing low middle income countries who, as we all know, are less responsible for less than 10% of the global greenhouse gas emissions. So by far, the vast majority falls of mortality falls in children. And that's how I got interested in the first place when I learned that. As Dame Lesley said earlier, it threatens all development and health gains of the past 50 years and threatens to put 1/3 of the world back into extreme poverty. Now, as we've talked about earlier, that these risks or these illnesses that are occurring, many of them, the diarrhea, the pneumonia, the malnutrition, these are all not new issues to medicine. They're disease entities that we've dealt with for years, but we know that vulnerable groups will become more vulnerable and least able to adapt. And so we often call climate change a risk multiplier, or essentially a poverty multiplier, and it will widen the gaps in resource and health between those who can and can't afford to adapt. So why are children more vulnerable to climate change? So as we say, as Dame Lesley said earlier, children in particular have higher metabolic rates, and they breathe faster than adults, higher respiratory rates. And so per kilogram of body weight, they are far more dependent on clean air, good food, and clean water. They also are highly dependent on their caregivers to keep them safe, say from a flood or a bushfire, or to give them water if it's getting hot outside. Their behaviors are very different than adults. So we know that they lack some of the protective behaviors. They're putting things in their mouth constantly. They're immune systems are far more immature compared to adults. And as we've said earlier, these lifelong, these insults accumulate and become lifelong. And so they are cumulative, and they have longer to live. So as we said earlier, I will go through a few of these specific events. We know extreme weather events such as cyclones and floods. This picture is actually from the US in 2017, when we were about to be hit by 3 cyclones, all within about a week of each other. It was just extraordinary to see this picture. We know that the number of weather-related natural disasters has tripled since the 1960s, and in 2019 caused 24 million people to be displaced from their homes, with its mental health impacts, with its disruption to schooling, disruption of families. And we have, not only do we have the immediate injuries and deaths from that, but we have its sort of after effects, the increases in diarrhea, dermatological conditions and rashes, molds causing worsening respiratory illness, and the mental health issues. I'll go into these a little bit in more detail later. We know, excuse me, we here in Australia, oh, you guys do too, have extreme heat waves. And there's certainly data showing that there's a 6 to 25 time, factor increase in ED or ER attendances for gastroenteritis, asthma, dehydration during heat waves. And as stated earlier, it does lead to preterm labor. I think it's important to say, actually, that the 5 top causes of child morbidity in the world for children under the age of 5 are essentially respiratory illnesses. It is gastroenteritis, and neonatal effects, so preterm labor, obstructed labor, and all of that. About 45% of that is there's an overlay of malnutrition making all of those worse. So climate change will make all of those conditions much worse. So in terms of heat waves here in Melbourne, at least, we have the number of days over 35 degrees will triple in Melbourne by the turn of the century. But if you actually look up in the more tropical regions, they will spend most of the year in greater than 35 degrees. And that I assume is worldwide. And where does this impact kids? So we've talked about heat impacts, and we know how unpleasant they are. As somebody, I think, said in the chat about the risk of obesity. So we know that sport here in Australia is certainly embedded in Australian culture, and kids normally play in their backyards. They participate in school sport and organized sport. But then afterwards, I think because of the heat waves that we experience, constricting sporting activity is a concern, because only 1/3 of children and 1 in 10 young people undertake the healthy lifestyle recommendations of 60 minutes of physical activity per day. I mean, even we know this, that as the heat goes up, it is far more difficult for us to go out for a walk, to go out for a run, to be out playing cricket, all of those sorts of things. And then we also know that extreme heat really impacts classroom learning. And there have been studies from the US showing that children, that extreme temperatures lead to decreased learning productivity and poor exam scores in school. And that average student achievement falls by an equivalent of 1% per year for each additional degree in Fahrenheit. And obviously this has equity issues, because it's really the classrooms who can afford air conditioning, or the schools that can afford air conditioning, who can bring down temperatures in their classrooms, versus those which cannot. So we know in the US that Hispanic and Black communities, schools there, these impacts are amplified. The Australian bushfires, where we had here, we lost an area approximately the size of Syria or Cambodia at the beginning of last year due to the bushfires. But then we also saw an additional 3,000 people hospitalized from the pervasive bushfire smoke that covered Canberra and Sydney, particularly, and the trauma that is still ongoing from that. We've spoken about air pollution, on the effects of the fetus and the newborn. Here in Australia, asthma affects 1 in 9 children. And we know that airborne allergens, pollutions, and ozone all increase emergency room visits and hospitalizations. In terms of traffic-related pollution, all due to the burning of fossil fuels. Not only do we have those elevated pregnancy risks as discussed earlier, but there's also been studies to show that there is slower attainment of developmental milestones and reduced cognitive function throughout early childhood and into school. And one lovely study from the US showed that children in prams or strollers are exposed to 60% more pollution than adults, because the prams and strollers are located down at tailpipe, at the level of the tailpipe compared to the adults, which I thought was fascinating. I think overall, globally, given my interest in international health, 93% of the world's children, which is a shocking percentage, that's almost all, live in areas where PM 2.5 levels are above the WHO quality guidelines. We know that worldwide, adults and children, there's almost 7 million deaths per year due to air pollution, and that's what 0.1. We have 7 billion right now, so that's 0.1%. To highlight the effect of highly polluting cook stoves, which are mostly burned, in most low-income countries where they use these cook stoves to cook, and they need to go out and gather wood. So we have indoor air pollution is responsible for 1 million child deaths annually from respiratory infections. And not only do you get the increased deaths, but it, as we all know, it depletes the forests of the trees, and which are the carbon sinks. But there's also major personal security risk and lost opportunity for those for other productive activities. So it's mostly women, it's mostly children that are going out to collect the firewood. And as they use up their firewood, they're going further and further out to collect that. And so therefore, what the security risks for those who are out there gathering, the women and children gathering. And also the further they go out, the less they can attend school. The less they can attend school or do maybe some income generating activities at home. We know that there are persistent associations between increased temperatures and child diarrheal diseases here in Australia and globally. And we expect an increase in diarrheal admissions amongst Aboriginal children in Central Australia by mid-century. And I was just out in Alice Springs working, and the diarrhea out there, it is just, profuse diarrhea. We also know that there will be at least with malnutrition an additional 100,000 additional deaths under 5 from global malnutrition. Here's an example from Australia. When we had the cyclones in 2011 take out it disrupted the entire banana supply. And bananas went from $3 a kilogram to about $15 a kilogram. And I had a toddler at that time who was eating a lot of bananas. We know that there will be increases in vector-borne diseases worldwide, and that there will be an increase of about 30% of children living in a potential malarial transmission zone. And we know that 70% of all malaria deaths occur in children under the age of 5 years. There's also an increased risk of dengue, schistosomiasis, the encephalitis viruses, Zika, tick-borne diseases, and all those others. And then mental health. We know that significant numbers of children and adolescents suffer moderate PTSD symptoms even a year and a half outside of a cyclone. And these longitudinal studies of children who were affected before the age of 5 have increased mental health disorders, particularly anxiety, leading into adulthood. We know that there are adverse long-term effects on cognitive function, learning ability, and academic achievement from primarily these extreme weather events. And that we have also seen that disaster-related prenatal maternal stress are associated again with cognitive, motor, and speech delays in infancy and early childhood. So I like to think a little bit more holistically than just the physical medical conditions that this will worsen. And I like to look at it from a child rights framework, so child protection, child development. And we certainly know from a child protection standpoint that parental stress and decreased social supports have definitely been linked to higher risk of neglect, abuse, and maltreatment in children. We saw that after a hurricane in the US, there was a 5-fold increase in non-accidental traumatic brain injury in children. So that is like shaken baby, or shaken baby. And that we've also in rural Bangladesh saw unintentional injuries and parental violence against children after the floods. And I'd also like to point out that this is also a very gendered issue as well. So girls and women are especially affected because from climate change. So they suffer a greater proportion of deaths and disability during floods and cyclones. And this is very much cultural. So in many places, girls aren't taught to swim or climb trees compared to boys. Girls are often dressed in more restrictive clothing like saris, and therefore aren't able to swim as well. And also culturally, many women are, and girls and women try and wait for their husbands to come home before fleeing something like a cyclone or flood. Girls and women are subject to sexual abuse and harassment, particularly in like in emergency centers after a cyclone or a flood, where they're often separated from their families and from their parents. They're often pulled from schools to do paid labor. They're sold into marriage or have to enter the sex trade to support their families. So I'm just going to read a few quick quotes from Plan about adolescent girls and climate change. We need to promote the girls. They don't leave their homes during times of crisis and disaster. It's also difficult for rescue teams to find girls, or they leave their homes later than the boys during cyclones, since they are primarily responsible for livestock and household. There is a mass tomb of victims from the cyclone in Bangladesh, and most of them are women and girls. From a girl in Ethiopia: during drought periods, we sell firewood. It takes an hour to collect the firewood, then another 2 hours to walk to the nearest town. We start at 4 a.m., even 3 a.m. If we don't manage to sell the firewood that morning, we have to stay at the market all day, and it keeps us from going to school. And then here, after cyclones, families think their condition is worse and they send their daughters to get married. Almost 50% of girls drop out of education because of early marriage. And in very remote villages, it is probably more like 70 to 75%. And then lastly, I want to bring up that climate change will be possibly the biggest driver of population displacement this century, with an estimated 150 to 200 people to move by the mid-turn of the mid-century. As being the refugee fellow for a few years here at the Children's Hospital, I know already currently we have about 70 million people displaced from their homes or in 2020. So imagine this number doubling, and how imagine this number doubling or tripling by 2050, and already how much disruption this has caused socially and economically in Europe and here in Australia. Those the outcry of people coming in. It will obviously lead to exposure to food riots, political instability, and uprising, societal breakdown, and how that disrupts families and schooling. And that 70% of nations explicitly cite climate change as a national security issue. So I won't go into what we can do. I assume that's what our discussion will be about. But I really do think that we need to look at the well-being of future generations and really involve children in participating and setting the agenda, as we've seen in the climate strikes. At least that happened here in Australia just on Friday. And this will be the start of their strength. Thank you very much.
Thank you very much indeed, Karen, for particularly for shining a light on the gender issue. I think the figure I heard most recently was that women and children are 14 times more likely to die in a natural disaster than all the reasons that you so eloquently put. So thank you very much to you and to Sari Kovats for your talks. And I'm now going to hand over to Panikos, who's going to share the discussion. Panikos.
Thank you very much. And thank you everyone for excellent presentations, and thank you for the attendees for joining. We will try to go through a few of the questions from the Q&A box, and also I'm going to start with my question. As an obstetric doctor, I would like to ask the speakers if they think that the heat has a direct effect on the fetus, or is it because third world countries and people with lowest socioeconomic status usually live in countries where the temperatures are higher, and that's another point which we might need to take into account when we finalize a conclusion about if the heat is affecting the fetus or not.
Yeah, I mean, the studies on heat look kind of temporal change, not cross-sectional studies, because you're right, if you were just looking cross-sectionally on climate risks, then it's too confounded, because the difference is certainly between tropical and non-tropical areas. You know, there's a lot of important other contextual differences. So the evidence for heat risk is really to take a single population and then look at the outcomes over time. And you're essentially comparing outcomes on very hot days to less hot days. So that's why we have more confidence, because it's such an acute effect. We have problems looking at chronic effects of heat. So unlike air pollution, where you've got quite robust measures of chronic and good understanding of chronic exposures, we don't do that in heat so much, because the evidence isn't as strong and there's other things going on as well. So I hope that answered your question.
Yeah, thank you very much. And the next question is from Dr. Adi. How has the reduction in outdoor air pollution during lockdowns affected children's health, not excluding the possibility that exposure to indoor air pollution and less physical exercise may have been worse?
So to the extent that outdoor air pollution has declined in lockdown, which it has done, although I think it's gone up, then that would have had an immediate benefit on health. And I think there are some papers, certainly I've seen a paper from China showing that exposures have reduced. And they also did it in the Olympics, you know, where there was a very drastic cut of emissions, and then they were able to show the benefit in terms of reduced hospitalizations as well. So we've got a lot of evidence there that, so we can assume that there would have been a benefit in terms of short-term respiratory outcomes. Interestingly, around indoors, you know, people were indoors more, and obviously there's a big socioeconomic gradient in terms of access to outside green space and access to gardens. And we know this because there have been surveys done quite recently by Public Health England. So to the extent in which you have poor housing quality, then your exposures during lockdown will have increased, you know, and that includes overheating, indoor air quality, and other factors, lack of physical activity. So yes, and they would have exacerbated all the inequalities that we have already. I haven't seen a lot of data on that directly, except for the heat wave. So we know the heat wave in 2020 actually had a massive, nearly double the impact compared to the heat waves in 2018. And this is all on the Public Health England website. Because the people who are at risk of COVID and more likely to self-isolate are also those most at risk of high temperatures. So there you can see that it's the same risk groups, which would explain why there was such a big impact. I think it was like 2,000 excess deaths for the 2020 heat wave, which is quite a lot. Did that answer your question?
Yeah, thank you very much. So the next question is from Francis Macaire. Are you aware of any research exploring an association between prothrombin gene variant, heat, and stillbirth?
So I know a little bit about the prothrombin gene variant in terms of miscarriage and later pregnancy complications, and the data I think are a bit flaky in the sense that there are some studies that say that there's a correlation and others that say there isn't a correlation. But I don't know about anything specifically factoring heat into the equation. But Francis, I will look it up, and if you email me, I will see what I can find. But as I say, there's been a definite association between that and poor pregnancy outcomes in women that carry the prothrombin gene. It's very difficult to predict who's going to have the complication in pregnancy, and that may be that the poor pregnancy outcome associated with that genetic thrombophilic variant is determined as to whether the fetus inherits that gene mutation as well from the mother. But it's not clear.
Okay, thank you very much. Another question from Dr. Adi. What lifestyle measures are practiced in the warmth of Japan for them to have enhanced life expectancies?
I can answer that in the sense that I think the main reason for long life in Japan is around diet and other lifestyle factors maybe. I do know that they have quite a lot of heat-related mortality actually, which is surprising. Heat-related mortality is quite interesting in the sense that it's quite high in Japan and it's also quite high in Southern Europe. Whereas if you look at cold, the Scandinavian countries are really well adapted to cold and they have hardly any heat-related deaths. I mean, any cold-related deaths, sorry. And it's the temperate countries like the UK that do really badly on cold. But that doesn't happen with heat, except in the southern US, where people are very well adapted in the sense that everyone has air conditioning in the southern US. So again, if you look at the dose response, it's very small effects. Does that sort of? So I don't know. Japan are doing the same thing that we are in the UK. So the UK heatwave plan is actually one of the best plans globally, and it's copied around the world. So, you know, Public Health England have done a great job, and it's around, you know, targeted advice and looking at actions linked to alert systems as well.
Okay, thank you. There is a comment from Neil Coleman. I'm not sure if it's a question or can basically comment on that. This is a series about medical problems with global warming, but the economic aspects could lead to civil unrest and other adverse consequences, including on health. What would you say on that?
Yes, you're right.
Definitely.
Yeah.
I think the civil conflict happening there was preceded by a drought. Lots of the conflicts that happen in Africa, like Ethiopia, they're all sort of probably drought and other climate impacts. The fight for, or the fight for habitable resources, the fight for water, will cause many of these groups to fight and lead to skirmishes around about land and territory. It's all based on that. We know that there are multiple conflicts over water around the world. There's actually a website that actually documents those, and leading as well to civil conflict.
Thank you. And one more question from Dr. Adi. Is low birth weight, especially in males, associated with greater risk of developing type 2 diabetes mellitus earlier, later in life?
I've certainly, anecdotally, I've heard this, you know, but I don't have the actual data behind it. That there's something about being low birth. theory is that low birth weight, the babies will have greater affinity for holding on to their sugar, I guess, and that potentially can develop diabetes. But I'd have to look at the data. I'm not sure. I've heard this anecdotally.
Okay, thank you.
So that low birth weight is associated with later essential hypertension, but I don't know if it directly correlates it with diabetes, but that's not my field of expertise.
So a question for all the panelists. What would you suggest to the participants of the COP26 conference, which is basically the 2021 United Nations Climate Change Conference taking place this year in Glasgow? What should we be putting in place to prevent deterioration of this situation?
I'm going to be flippant now. A non-lethal version of COVID. We've all stopped flying around and we've locked down.
Yeah, I'll add to that. Just there's more commitments for adaptation, and particularly linked to finance. So there's a lot of focus around carbon reduction commitments, but the UK government actually has a race to resilience ambition, and it's clear that a lot of places need extra support to make their health systems more resilient to climate change. So.
And I would like an increased focus on vulnerability and equity and inequity, essentially. I think also if we looked at it as the well-being of future generations, I mean, we really need to shift to looking at future generations. Most politicians these days, they're looking in the 5 to 10 year space. I mean, we really need to look further out into 50 years and see what the world's going to be like and start preparing for that.
If no one else has any comments or any questions to each other.
Well, I'd like to just say thank you as well to the speakers, but also to Karen for getting up in the middle of the night to come.
Yes, it's amazing.
That's okay. I get to go to bed. It's still dark here. No problem. Thank you. Thank you for inviting me.
Several of the audience, several of the participants or attendees have commented and said thank you for early. So I'll pass it on to you.
Easily. Thank you.
Okay. Thank you very much. I would like to remind you that this is a recorded webinar, so you can watch it again. If you are watching the recorded version of the webinar, in order to get CPT points, you will need to watch it on demand through Zoom. And full resources and the recording link will be sent in the follow-up email. The next episode will be on the 8th of June at 6 p.m. and this will be focusing on mental health in a planetary crisis. And this will be episode 7. And we would like to say a special thank you to Michael Rapp for his generous support enabling free access to this webinar. And again, I would like to thank the speakers and the attendees for joining this webinar today.